try to understand anemia through a behavioral lens.
One thing that I wanted to start off with is that access and services and information is essential for programs such as anemia to work. But programs have expanded access in terms of iron folic supplementation, take-home rations, screening, and nutritional information. And when we're thinking about behavior, we usually think about a linear journey, like I'll tell you, right? So the idea of behavior change would be if we're able to drive awareness for iron and folic acid supplementation, take-home rations, nutritional information about iron-rich foods, or even screening, the idea is that automatically people will build an intention or motivation within themselves to engage. They will take action and therefore take the IFA pills, have the take-home rations, eat nutritionally diverse meals, and screen when required. And once they do it once, the idea is that they will adhere to this behavior as well in order for it to become sustainable. But the problem is that the more I understand about behavioral science and the more projects that I have done, we have to understand that while access and awareness is important, it's not sufficient for behavior change, right? Because behavior change does not follow this very, very linear journey. And just building from Saurav's point, right? Awareness is important, but just because a person is aware about IFA pills, about iron-rich foods, and its importance, it doesn't necessarily mean that a person will believe that this is important for me or this information is relevant for me to do, right? And therefore, there's no motivation that is generated within them to do anything that is different from what they're currently doing. So therefore, there's a gap between that awareness creation and that intent generation overall. And let's take it a step forward. Now, even if a person has built some sort of like intent or motivation saying that, okay, anemia is a condition that is serious and I need to do something about it, still sometimes that doesn't translate to action, right? And we've seen this in our lives as well, let alone only in the stakeholders that we try to build this behavior within. Because sometimes, even though I might know anemia is khoon ki kami, I still feel like if I take those pills, I'm going to have a bad stomach and I'm going to have black stools, which is why maybe I'm not going to do it. So again, what we're seeing is a gap between intent to actually the action taking place even once, right? Similarly, I understand that nutrition diets are important, but again, it's hard for me to get those foods to my house overall. So again, there's a gap between intent to action. So even if we solve for the fact that a person is doing the action once, where they take the IFA pill or they're having an iron nutrition diet one time, we believe that will happen again, but that's not true, even with our behavior. Because I can take the pill once, but I might not adhere to my 100 or 180-day regime of IFA pills as well, right? Because there's no routine or there's no habit that is built. Similarly, I can have an iron-rich food once, but if it's not coming into my house on a routine basis and I'm not cooking it on a routine basis, it's not going to sustain and create that behavior change. And as all of us know, and sort of mentioned as well, anemia prevention and healthy eating is a behavioral problem because it requires this sustained behavior. And in many cases, I think most of our interventions are focused from a supply side, from an access driven, and from an awareness driven aspect, which is why I think that behavioral angle has kind of like fall short, which is why even after all the effort that we have done, we still see high rates of anemia in multiple places that we are working. And therefore, this is more of like an urge and a push to kind of say that this behavioral problem is actually shaped by the routines that people have. It's shaped by the decision-making structures in the household. It's shaped by the context of who's deciding what food comes into the house. And only if we start understanding some of these behaviors or these behavioral barriers, we're better able to understand what are the design solutions we can make that is not only communication-led, that has to be multiple level of interventions, equipping the ASHA or the ANM to speak more convincingly and more relevant for our community members in order to make these healthy behaviors easier, more relevant, and more sustainable overall, right? And now I'm going to quickly talk to you a little bit about some of what are the interventions and what is some of these behavioral barriers that we have uncovered across multiple states that we have been working in. So I've been working in Gujarat, Rajasthan, and Chhattisgarh, specifically around issues around anemia. So within Gujarat, our focus has been on reduction specifically in adolescents and pregnant women to kind of like push dietary diversity and IFA uptake in Tharad or Banaskantha. Within Rajasthan, we focused on improving dietary practices among pregnant women in Karoli. And in Chhattisgarh, we've looked at exploration of behavioral barriers to promote the uptake of healthy eating or healthy diets among adolescents in Mahasamund. So again, the idea was in all of these states that we have worked on in the very specific districts, we started off with number one, trying to understand what is already being done in that particular area and what is the research saying. Post that, we go in and actually meet with our end users, meet with pregnant women, with adolescents, and try and understand from their point of view what are some of those behavioral barriers that are playing out. From that, it's not just, it doesn't stop here. Research is not for research's sake, but we think about how might we co-design some of these solutions with our critical stakeholders, which might be CSO partners, government, but also with our end users itself to see if these interventions will actually work. And then we want to pilot these interventions to see, are they actually effective in creating the changes that we want, right? Because again, I think evidence generation is quite critical to understand what are those interventions that are actually going to change the behavior. And then post seeing that, an actual scale out and implementation across various regions. So for now, I'm just going to give you a quick deep dive into a couple of our interventions and a couple of those insights just to give you a flavor of why this behavioral science lens is critical. So when we're talking about pregnant women and when we were trying to understand what are some of those behavioral barriers within Harar in Gujarat, what we saw, and we've seen this in multiple places as well, for pregnant women, the symptoms of anemia is perceived as the symptoms of pregnancy related to pregnancy as well. Tiredness, weakness, pale, they feel like this is more just a part of pregnancy, and they don't feel that this is a condition that needs to be managed overall. This creates like low risk perception and also like low urgency for any sort of new behavior that needs to be taken up for anemia management. And therefore, even if you speak to the woman about how you need to do an IFA pill, have diverse diets, for them it's like, but there's no problem. Why should I do something extra? Secondly, I think all of us, all human beings, and more so our end users as well, they focus on a treatment mindset. Only if there's a problem, I'm going to do something extra. I'm going to take some medicine. Ye fazul ki medicine, why should I take an IFA pill? I think I should limit the medicines to my body because I feel like that's going to create a bigger problem. And one of the critical touch points where we can drive relevance for anemia as a severe condition or an important condition is actually when we do the HB test or during the ANC visits. But over here also a lot of women tell us that I don't know what the test results are. It's communicated in a very hard way. It's not explained to me and I don't know what I'm supposed to do after. It's just a number. So what our intervention was that during the screening, the intervention was to help the ANM actually have a card that helps explain to the woman what does that number actually mean? What does a 7 mean? What is the whole scale? So they're also able to understand that is this a good number? Is it a bad number? And they also try and relate it to some of the symptoms that they might be feeling that they might have wrongly attributed to only pregnancy. But again, after that, tell them that it's not a problem. All you need to do is just 3 behaviors. And again, the 3 behaviors we introduce to them is the IFA supplementation, diverse diets, as well as the THR that is given to them. Again, grouping the behaviors together helps them better have a holistic way to kind of like manage their iron and reduction in anemia overall. Secondly, I wanted to also tell you another part. It's about making our current interventions more effective. A lot of our ANC visits have tests in where they kind of like check the woman's weight. But in many cases in Karoli, for example, in Rajasthan, what was happening is that women did not know when the weight was checked. Is this a good amount of weight gain? Is it bad amount of weight gain? They did not know what was the relationship between weight gain and nutrition overall. And this touch point of the ANC visit when we're taking the weight, we help the ANM basically get a small weight gain prompt tool where during those visits, she could be giving it to the pregnant woman based on if the weight gain was appropriate or not appropriate. So for example, if the weight gain was very, very low, you give the woman a red card and basically say that now you need to do these couple of steps in terms of nutritional diversity in order to improve your weight gain. Versus if the woman has been progressing well, she gets a green card. So again, it's visual feedback that she is getting with clear indication of what are the changes that need to be made that can be taken home as well. So this is improving the effectiveness of a touch point by giving the feedback to the woman so she's able to take action, but very specific actions. And similarly, as we all know as well, a lot of the pregnant women in Karoli over here as well, they did not go for the ANC visits, but they did really trust a private doctor. Right? So the private doctor's words really carried weight and was very, very credible advice that they said that they would change their behavior for. And therefore, we can't convince every private doctor to tell about weight information or weight gain and why dietary diversity was critical, what we did do was we created or redesigned a small uh, prescription pack. So where they write the doctor's prescription, at the back, we basically had information about dietary diversity and what was very critical for them to introduce in their diet. So this simple step, a messenger of a private doctor giving their prescription on this suddenly increases the importance of the information, and the wife but also the husband immediately takes note to say that this is an important behavior because the doctor has told me this behavior. And again, just adding to Saurav's point as well, right? For pregnant women, the issue is that anyway, most of our diets in the households are restrictive, very starch based. But because you are pregnant, there are a lot more classifications in terms of what food is good or bad. So they further have restrictions on their food, which is why it's very, very critical to have a critical source that they actually believe say that it's this garam food that you're not eating actually is very, very critical because it might be actually adding for that dietary diversity as well as iron rich foods, which are very, very critical to you. But they're not going to believe anyone, but potentially coming from a private doctor is something that they would believe. And just building on the point of Saurav about engaging key decision makers as well. A lot of our information in the health system only goes to the woman about IFA, about dietary diversity. But in many cases, we all know that while women are supposed to be talking about nutrition and thinking about the household health, they have very low decision-making agency and authority about what food comes in, what money should be spent where, and what gets made in the household. It is the husband, it is the mother-in-law that's making these decisions overall. And therefore, in Karoli, we basically ensured that the migrant worker husband was actually engaged because he was the one who was sending money home to buy the fruits and vegetables. And because this person was very far away, we actually created like a small WhatsApp group intervention where we shared these small snippet videos about talking about dietary diversity, which was very, very critical. And we actually wanted to check if it actually serves an increase in the amount of money that gets sent home, but also the added focus and support that the husband gives to the wife to say these are the foods that are important. And similarly in Tharad as well, we ensure that we engaged mother-in-laws to kind of help them understand that they are the key decision makers and how could they include at least 2 to 3 more iron-rich foods into the diet of the household. And therefore, the whole household, including the pregnant woman, gets the nutrition needs that she actually needs. And the third one was, like we had mentioned before, food allocation is very gendered. First, the husband eats, then the children eat, and then the woman eats usually. So the idea again is that how do we kind of like shift and move towards everyone eating together to kind of like create a shared moment versus this hierarchy of food, because otherwise the green leafy vegetables are significantly reduced and the woman is only eating rice and pickle in the end because that is all that is left in the household overall. And the last part I wanted to talk a little bit about was we can't just focus on building awareness and intention in a person. We also have to focus on how do you actually build that habit or those rituals in the household. So, for example, for IFA supplementation, what happens is the fact that there's very short-term costs of the side effects from the medicine overall versus the long-term gains of actually your iron levels increasing. And therefore, there's an initial people might take the medicine for 2 to 3 days and then they drop off, or they claim to forget when actually they just don't want to take the pills. So we ensured that when the Asha was actually giving this information, visiting on the home visits, not only to just say, take the IFA pills, but also help her cope with these side effects and these small costs, saying that it's for a very, very short period of time, and really help her to kind of like build this routine, which also uses, for example, a vitamin C rich food, such as a small lime in the water that helps the adoption, but also like prevent some of those negative side effects she might be feeling. We also urge her to try and create a routine in the household saying, okay, what do you generally do in the night? Okay, is there a specific thing that you always do? And can you do this right after? So we try to anchor it to an existing behavior. So we're piggybacking on existing behavior to help her build a routine to ensure that she takes the iron pills every single day. And we also encouraged her to find someone in the household to remind her, because otherwise too much onus is placed on the woman. So she asked her, like, will your husband remind you? Will your mother-in-law? Will your other child remind you? And in this way, we're actually creating a system where she's able to form a ritual or a habit around this pill taking, which will ensure that it is a sustained and she actually finishes the 100 or the 180 days. And the last intervention I wanted to quickly kind of like speak to you all about was also the interventions around adolescents, right? So again, we can't think about programming around anemia in the same way for a pregnant woman and for an adolescent as well. When you're thinking about an adolescent, they their dietary habits are very much focused on just sustenance. I need to feel full. They're not focused on nutrition at all. And therefore, they don't understand what is the problem of unhealthy diets. But also, we might understand that adolescents are exercising agency to make dietary choices, especially in the evening after they come back from school. They're buying the packaged chips, and they are really like eating food as a group together. So it's very important not to just give them information, but really ensure that the information on healthy diets is actually becoming more fun, more social, more aspirational, because that's actually going to change the behavior of a youth. So what we planned for an intervention in Chhattisgarh was actually called Kale Kalaiva, which was supposed to actually put together the association of healthy food and sports, right? Because if you're talking about how athletes or people who are good at sports are actually eating better, it might help them create the association between healthy eating and also like getting and feeling stronger overall. It also is creating like a peer norm that all the people who are athletes and all the people who are aspirational are actually eating well and thinking about what they eat as well. And therefore, healthy food becomes more relevant, more fun, more aspirational, and more vivid for them overall. And that's the small event that we've actually like rolling out, and then we're doing a baseline and end line to actually see, is it creating a sustained behavior change, because we're also trying to introduce these small easy habits for them to start introducing in terms of eating a couple of nuts or eating some chana or eating some of these green leafy vegetables in ways that is better for them. And the last one is that also adolescents seem to not be very aware about what food they're eating, and they're always not really reflecting on what's going into their stomach. So we realized that we could create a campaign on Aaj Kya Khaya, which could get them to influencers actually ask them like, what did you eat today, to help them think about what actually did I eat. And also in Aaj Kya Khaya, people can, or influencers can explain what are the good things that they have eaten: green leafy vegetables, some meat, some calcium rich foods, all of these things which are very proteins, millets, all of these foods that can become aspirational if they hear it more from influencers. So मैंने आज ये खाया, आज आपने क्या खाया. So in this way, we're actually creating a more reflective moment in the youth, but they're also learning from what other influencers actually eating in places. So they'll get motivated to eat better overall. Again, I know I went through a lot of interventions, but my aim was just to show you how using a behavioral science lens can actually see how an ASHA interaction, an ANM interaction, existing touch points can become a lot more effective, because it's actually taken into account a behavioral barrier. And similarly, we have to move away from just awareness-based communication to really thinking about various types of interventions that can work based on the audience that we do have as well.